double quoting the word antiplatelet therapy over here because we have now two classes of drugs, a patient who is coming with an antiplatelet therapy and a patient who is coming with an anticoagulant therapy. So we have two categories of drugs and we'll discuss both of them. Before starting the lecture, I would like to present what would be the broad outline of this entire lecture. A patient who is presenting with a particular drug, be it antiplatelet or anticoagulant, you will need to know when you should modify the particular dosage of any of these drugs. And also, you also need to know, on the other hand, when you should resume these particular drugs after your operation or after the operative period is complete. So we'll discuss both of these topics in today's lecture. Moving on to the first slide, what is the necessity for having an antiplatelet therapy modification or an anticoagulant therapy modification? This entire thing boils down to hematological risk assessment of a particular patient. Now, what is the significance of HRA? This is a term which is very broadly used by the doctors of anesthesia, and it essentially involves evaluating and managing the needs for the RBC transfusion as well as maintaining the integrity of the patient's coagulation ability, including any intrinsic bleeding disorders or coagulopathy or the medications the patient is having. So you have two components of HRA, the need for RBC transfusion and the patient's coagulation ability. The ultimate goal of the HRA is to minimize the transfusion and prevent complications such as hemorrhage and thrombosis. Now, in which situations do we actually require the hematological risk assessment? You can see over here the class of patients. Patients refusing allogenic RBC transfusion. This is a very popular concept in the Western world known as the Jehovah's Witness. Okay, so these particular group of people actually refuse allogenic RBC transfusion. Second, no or insufficient number of allogenic RBCs available. Third, patients with a history of bleeding disorder, patients with a prolonged prothrombin time, patients with a prolonged APTT, activated partial thromboplastin time, patients with a low platelet count, a platelet function defect, and the today's topic for discussion, which will be antiplatelet drugs or patients on anticoagulant medications. We are not going to discuss the other categories further, but we are going to focus on the antiplatelet and the anticoagulant medications today. Proceeding further, before starting the topic, we should also know about the procedural bleeding risk that any procedure or the operative therapy is going to be performed on the patient. You are sending a patient for a pre-anesthetic checkup, and you are informing the doctors of anesthesia that this is my surgical plan of management, and we can classify them into two categories: the high and low procedural bleeding risk. Exact definition will be 2 day risk of major bleed between 2 to 4%. In the low category, it is between 0 to 2%. A brief description: heart valve replacement, coronary artery bypass, abdominal aortic aneurysm repair, neurosurgical, urological, head and neck, abdominal or breast cancer surgery, bilateral knee replacement, and others, which you can see over here: TURP, kidney biopsy, polypectomy, peg placement, vascular and general surgery, and any major operation with a procedure duration more than 45 minutes. These come under the category of high procedural bleeding risk. On the other hand, we have cholecystectomy, abdominal hysterectomy, endoscopy with or without biopsy, and other procedures. We have pacemaker or defibrillator insertion and other procedures which you can see over here: hemorrhoidal surgery, abdominal hernia repair, hydrocele repair, axillary node dissection, and others. These fall under the category of the low procedural bleeding risk. So depending on which category your procedure falls in, the concept of bridging therapy will arise when you are going to manage these patients. Now, let's proceed further and we'll begin with the first you have a patient who is now presenting to you, and the patient is taking antiplatelet therapy. Okay, so what are the common antiplatelet medications? We have a brief description over here: aspirin, dipyridamole, cilostazol. Aspirin and cilostazol, I have seen in person at CMRI. Clopidogrel, ticagrelor and prasugrel, cangrelor, abiximab, epitifibatide. Okay, so we have these common antiplatelet medications. We have combinations of these antiplatelet medications which are used in the term of dual antiplatelet therapies, and we'll begin classifying them and managing them one by one. First, what is the importance? These antiplatelet therapies provide a high degree of protection against myocardial infarction, stroke, and peripheral vascular occlusion. If you interrupt these antiplatelet agents, particularly in the inflammation inducing perioperative period, you are placing the patients at a higher risk of thrombotic events, and you must weigh the risk against the risk of increased surgical bleeding, which you are going to face. So let's have a literature review on aspirin first, the first drug. A very generalized statement: unless otherwise contraindicated, lifelong aspirin is recommended for all patients with coronary artery disease, cerebrovascular disease, peripheral occlusive disease, or prior venous thromboembolism. Withdrawal of aspirin in patients with stable coronary artery disease has been shown to be associated with a four-fold increase in the rate of death, compared with patients who are appropriately treated with aspirin withdrawal proceeding 10% of acute coronary vascular syndromes. So you have a 4x increase in the rate of death if you are withdrawing aspirin. There was a meta-analysis including around 135,000 high-risk patients, and aspirin was associated with 22% reduction in vascular deaths. Data supporting aspirin to use for primary prevention is less robust. It is showing a modest reduction in the risk of MI, stroke, and colon cancer, but there is an increased risk of GI bleeding and hemorrhagic stroke.
Uh,
One of
Shop,
the
I didn't
yes, sir.
understand the first paragraph. Can you explain the first paragraph again, please?
This one, sir.
Yeah.
Okay. So the withdrawal of aspirin in patients with stable coronary artery disease has been shown to be associated with a fourfold increase in the rate of death. This is the first point. This was compared with patients which were appropriately treated with aspirin withdrawal preceding 10% of all acute cardiovascular syndromes. Sir, actually, this was a part of a trial study in which they had withdrawn the aspirin in patients with stable disease, comparing it to patients with an acute setting of CAD, and there was a difference of there was a fourfold increase in death, sir. So they have the ACC guidelines were framed according surrounding this study, sir.
ओके ओके ठीक है.
Next, this slide was particularly important. This is a continuation of the literature review. Now, a very famous trial was done, known as the POISE 2 trial, peri-operative ischemic evaluation 2, which found that there was increased rate of major bleeding without a decreased rate of cardiovascular events or mortality. Now, these were patients who were undergoing non-cardiac surgery and were randomized to take peri-operative aspirin. Now, in such a patient, when such a result was produced that there is an increased rate of major bleeding and there was no particularly significant effect of a decreased rate of cardiovascular events, there was a difference of opinion between the cardiologist and between other medical specialties that should we or should we not continue with aspirin in the period. It was later found out that there were methodological issues which had crept into the trial, and there was difficult to draw conclusions regarding aspirin discontinuation in patient at high risk of adverse perioperative cardiovascular events. Thereafter, in 2014, ACC and AHA, these guidelines recommend that for non-stented patients with a high risk of CAD or cerebrovascular disease, it may be reasonable to continue aspirin when the risk of potential increased cardiac event outweighs the risk of increased bleeding. If your cardiac event risk is much more higher than the risk of increased bleeding, continue aspirin. For patients with prior acute coronary syndrome or PCI, aspirin monotherapy should not be stopped in the perioperative period. So you have patients who are continuing on a tablet, ecosprin or aspirin 75 in a ODHS dose. So this is what the guidelines recommend, and this is what we are actually following.
What does the guideline say
On,
about a stented patient, Sharp?
yes,
Where
sir. We have
where's
a
the
slide
stent?
on the stent.
Okay, you're
Yes,
coming
sir.
in
This
later.
is the
Okay, okay,
slide.
okay. We take it in stages. Okay, fair enough. We're going to address that later. Yeah.
Now, we have a short description on the dual antiplatelet therapy. The dual antiplatelet therapy will have a combination of these particular drugs, which are commonly available: aspirin, clopidogrel, prasugrel, ticagrelor, and cangrelor. The advantages of dual antiplatelet therapy over aspirin monotherapy is that there is a much lesser risk of stroke, myocardial infarction, and mortality. It is also important that the cessation of antiplatelet therapy is a major independent predictor of stent occlusion. This is an important point we should remember. It is associated with a 2 to 5-fold increase in mortality and infarction rate if you are stopping the antiplatelet therapy. 20% incidence of thrombosis in those with uncoated stent, which is also known as the bare metal stent, and 20 to 45% mortality in patients with drug-eluting stent. So we have a flowchart over here. We'll begin patients treated with PCI undergoing elective non-cardiac surgery. First group of patients, bare metal stent treated with dual antiplatelet therapy. Now you can see the timings over here: 0 days, 30 days, 3 months. The patient is undergoing elective cardiac surgery after the placement of bare metal stent on 0 days. There is no such recommendation at the point of 0 days. It is highly unlikely that the patient will go an elective surgery on day 0 after the placement of a bare metal stent. At 30 days, if it is less than 30 days since the bare metal stent implantation, the recommendation is a class 3. There is a high risk of harm. You should consider delaying the surgery since it is a elective case. At more than equal to 30 days since bare metal stent implantation, a class 1 indication is you can proceed with the surgery. Drug-eluting stent treated with dual antiplatelet therapy. This actually boils down at the period of 3 months. For a bare metal stent, remember it is 30 days. For drug-eluting stent, the classification now starts at 3 months. If it is less than 3 months since the DES implantation, class 3 indication, there is a harm, delay the surgery. Between 3 to 6 months since the drug-eluting stent implantation, you can discontinue dual antiplatelet therapy only in cases if delaying the surgery is a much more greater risk than the stent thrombosis risk which you are going to give to the patient on stopping the DAPT. So you have to balance out the individual patient assessment with the cardiologist, with the doctors of anesthesia, and the surgical team itself. Therefore, it becomes a class 2B indication. Proceeding with surgery may be considered. After 6 months since DES implantation, you can discontinue DAPT and proceed with the surgery, a class 1 indication in such.
Have they said, Sharp, how many days of withdrawal? They say
Yes, sir.
discontinue DAPT. How many days prior to surgery?
Yes, sir. Yes. We have a slide over here in which we are actually going to explain that when we should resume the DAPT after withholding the patient. It is in this slide over here, sir.
Okay, we can go reach that later. That's fine.
This is here, sir. For a patient receiving dual antiplatelet therapy, if P2Y12 therapy needs to be withheld, aspirin should be continued. The first point is aspirin should be continued throughout the perioperative period is possible, and it should be restarted post-operatively as soon as possible. Now, as soon as possible means that you are monitoring whether the surgery was a high risk procedural risk or it was a low procedural risk surgery. You are looking at the patient for a perspective of around 24 or 48 or 72 hours, depending on the surgery you have performed on the patient, and you are ruling out any major bleeding. So 2 points: aspirin should be continued. Second, other therapies, P2Y12 therapy should be restarted post-operatively as soon as possible. There is no benefit, there is no convincing clinical evidence suggesting a benefit to bridging the patient through the perioperative period on a IV antiplatelet agent when the DAPT is discontinued. So the bridging concept of bridging will mainly apply on the anticoagulant medications, not on the antiplatelet medication. It is a standard practice to discontinue the P2Y12 therapy 7 to 10 days before surgery to allow the regeneration of new platelets and minimize perioperative loss, because the mechanism of action of antiplatelet therapy makes it a irreversible inhibition. So the platelets have to be destroyed, and the new platelets which will get formed in the place will provide the necessary coagulation. It is also a highly individualized decision, and you need to involve the surgeon, the anesthesiologist, the cardiologist, and the patients in making this particular decision. So we are ending the antiplatelet therapy over here now, and we have 2 points in mind: continue aspirin, restart as soon as possible. If you're withholding the P2Y12 therapy, try and discontinue 7 to 10 days before surgery to allow for the regeneration, and make a highly individualized decision with consultation with other teams as well.
Okay, and no benefit of bridging therapy.
And we have no benefit of bridging therapy in case of antiplatelet medication.
Okay. Done. Dr. Upadhyay, do you have any comment?
Yes, sir. Bridging therapy, actually, it is not advised for antiplatelet agents. Sharp has told very correctly. But if there is high risk of thrombosis and you want to do a surgery, it's advised that you bridge it with aspirin. You can continue aspirin up to 75 milligram orally, perioperatively safely.
Right.
That is one of the oral bridging therapy. Other intravenous antiplatelet agents are also advised, which can be stopped 1 to 6 hours prior to surgery if you bridge them. But that depends, again, that depends upon the patient's thrombosis risk and the bleeding risk associated with the surgery.
Fair enough. Okay. My impression was antiplatelets don't really work for prevention of venous thrombosis. Does it, Sharp?
No,
Sir,
sir,
there is
it
no
doesn't.
convincing evidence
There's
over
no
it, sir.
convincing. So that's a separate issue completely. If you have a thrombosis risk, then you would probably use some other agents, thrombotic agents, isn't it?
Yes, sir. Sir, the use of thromboelastography is not very prevalent in every
No,
patient.
no,
So it is difficult to determine in such a case.
no, fair enough. Okay.
Uh,
Okay, go
স্যার
ahead.
স্যার
হ্যাঁ
স্যার
হ্যাঁ
স্যার
হ্যাঁ বলো অভিক।
এখানে বলছি টিরোফিবানের কোনো রোল আছে ডুয়েল অ্যান্টিপ্লেটেলেট থেরাপির এখানে ব্রিজিং এর ক্ষেত্রে আইভি টিরোফিবান
সেটাই ডক্টর নিধি বলছিলেন যে মানে দ্যাট ইজ সামথিং দ্যাট ইজ ভেরি
Yes,
নিউ।
sir. Yes, sir.
Right.
Tirofiban is there. And I think Cangrelor is there, which is P2Y12 inhibitor.
রিভার্সিবল
Yes, yes. Iptafibitide. GP2B3 inhibitors are basically used
হ্যাঁ
as
টিরোফিবান
agents. Yes,
ওটা
sir.
একটা আমি দেখছিলাম নতুন ওই ম্যামসি আপডেটে এটা দিয়েছে সেই জন্য আমি জিজ্ঞাসা করলাম
হ্যাঁ মানে thrombosis, by telling thrombosis, I just don't mean DVT. I mean cardiac thrombosis, coronary thrombosis risk,
Coronary
sir.
thrombosis, মানে platelet derived thrombosis আর কি, rather than
Yes. If it is
stasis
for
stabilized.
secondary,
Yep.
yes, sir. Secondary prevention, अगर दे रहे हैं उसके लिए, then you should consider.
Okay.
So we'll proceed on to the further slides.
Yeah, sure, sure.
We have two remaining a bit concept which we need to understand for a dual antiplatelet therapy. In the setting of a urgent or emergent surgery, your surgery can be a high risk surgery, high risk bleeding, or a low risk bleeding. Also, will you have a surgery which is urgent, which is emergent, and which is elective. So whatever we are learning in the previous slides over here, this was mainly in the context of elective surgery, where you had the provision of stopping 7 to 10 days before. You had the provision of bridging the patient using agents, or you had the provision of making a decision with the interdisciplinary team. Now, in case of a urgent or emergent surgery, following recent PCI before the completion of DAPT, this is for the time period when the bare metal stent is less than 30 days and the drug eluting stent with DAPT is less than 3 months, which we had seen in the flowchart. Interdisciplinary approach is mandatory, keeping in mind the same considerations described previously. What is it? For a low bleeding risk, the DAPT can be continued, whereas for an intermediate to high bleeding risk therapy, DAPT should be discontinued while continuing aspirin monotherapy if possible. Platelet transfusion may be necessary in this situation if DAPT cannot be stopped soon enough prior to surgery, because there is a very, very high risk of stent thrombosis in such a patient. So keep a platelet transfusion ready in case you are proceeding with an intermediate to high bleeding risk for an emergent or an urgent surgery. Another important concept lies in the concept of cardiac surgery in such a patient. In a patient undergoing cardiac surgery on cardiopulmonary bypass and systemic heparinization, which is done, if the patient was continued on DAPT, it was found that there is an increased risk of surgical bleeding, chest tube output, transfusion rate, and length of hospital stay by about 50%. According to the guidelines, the 2011 ACC AHA guidelines, for patients who are on DAPT and are now going to undergo elective CABG, they should continue with peri-operative aspirin and discontinue clopidogrel and ticagrelor at least 5 days prior to surgery. Discontinue prasugrel at least 7 days prior to surgery. Now, this discontinuation of 5 days and 7 days depends upon the half-life of the drugs and the metabolism that the particular patient is having. In case of urgent CABG, you have the two-pronged situation on an elective case and an urgent case. In an urgent CABG, clopidogrel and ticagrelor should be discontinued at least 24 hours prior to surgery. For drugs like tirofiban, eptifitabide, they should be discontinued at least 2 to 4 hours prior to surgery. Epsiximab should be discontinued at least 12 hours prior to surgery. So we have a classification out here for especially for a case in cases of cardiac surgery.
Essentially, what it means is, if you go back to that slide, what
Yes, sir.
Abhik was saying, I mean, these have a very short half-life. The
Yes.
tirofiban, the ftfibatidine, okay, these have very short half-life, so they can be continued till 2 to 4 hours prior to surgery because their
Yes.
half-life is short, as opposed to something like prasugrel, which has a very, very bad effect on platelet function.
Yes, sir.
Very robust. Okay, sure, go ahead.
So now we are going to proceed on the next section, which is management of a patient on anticoagulation therapy. So what will be the category of patients who are going to present to you and they will be on some anticoagulant therapy? Indications for anticoagulation therapy are atrial fibrillation, venous thromboembolism, and patients who had a mechanical heart valve implantation. The common anticoagulants used are the vitamin K antagonist, warfarin, unfractionated heparin, low molecular weight heparin like dalteparin, enoxaparin, fondaparinux, direct factor 10A inhibitors such as rivaroxaban, apixaban, and direct thrombin inhibitors like lepirudin, bivalirudin, dabigatran. Of them, the most common oral agents for a long-term outpatient anticoagulation is warfarin, dabigatran, rivaroxaban, and apixaban. How you should manage a patient in case of a anticoagulation therapy. We are again going to classify them into low risk, high risk, emergency surgery, elective surgery, what should be done before the surgery, when they should be resumed after the surgery. Minor surgeries may be able, you can perform them without interrupting the therapy condition if the continuation of the anticoagulant significantly increases the risk of major bleeding. It is a known concept. If you are continuing the anticoagulant therapy, there is a significant risk of increasing major bleeding. However, you can, in cases of minor surgery, you can continue to do so without interrupting the therapy. Next, in patients with moderate to high risk of thromboembolism, the patient should receive bridging therapy. This is according to the ACCP guidelines, American College of Chest Physicians. We have a slide dedicated to this, just the next one. In the low risk of patients of thromboembolisms, they do not require bridging. Resumption of antithrombotic therapy should occur 24 hours post-op in patients at low bleeding risk, whereas those at high bleeding risk should wait for 48 to 72 hours. Now, this is the suggested risk stratification for the perioperative thromboembolism. The risk stratum is high, moderate, and low. High risk, more than 10% annual risk for thromboembolism, moderate between 5 to 10%, low risk less than 5%. You have the three common indications: mechanical heart valve, atrial fibrillation, and venous thromboembolism. Let's start with the low risk. A low risk in a patient with mechanical heart valve, bileaflet aortic valve prosthesis without atrial fibrillation and no other risk factors for stroke. Obviously, this involves an interdisciplinary approach. You have to involve the cardiologists, the CTBS surgeons, the anesthesiologists, and the surgical team. Next, a bileaflet aortic valve prosthesis and one or more of the risk factors: atrial fibrillation, prior stroke or TIA, hypertension, diabetes, congestive heart failure, age more than 75 years. High risk, any mechanical prosthesis, any caged ball or tilting disc aortic valve prosthesis, recent, that is within 6 months, stroke or TIA attack. These come in the high risk. In high risk and moderate risk patient, perform bridging therapy. In low risk patient, you can avoid bridging therapy, and you can avoid bridging therapy, but it is also an individualized decision for a patient. Similarly, we have for atrial fibrillation, we have the CHADS-2 score. The CHADS-2 is we have written over here.
Sharp,
Yes, sir.
because Subanjali did that. This is important because in UK they follow the CHAD score. The CHAD score, C stands for congestive heart failure, H for hypertension, A is for age more than 75, D is for diabetes, and S I think is for stroke. Yes, stroke or TIA. Yeah.
Yes, sir.
Oh, it's given below. Okay. Yeah.
One and two.
Yeah. Okay. So that's given below. So Subanjali, that is the easiest thing to remember rather than the Caprini score. I mean, Caprini is a huge score to remember. Okay, just remember that. All of
Okay,
you.
sir.
So we have
Great.
the CHADS-2 score between 0 to 2, assuming there is no prior stroke or transient ischemic attack. CHADS-2 score between 3 or 4 comes in the moderate risk. CHADS score of 5 or 6, recent stroke or TIA, rheumatic valvular heart disease, come in the high risk. Venous thromboembolism, more than 12 hours previous episode and no other risk factors. VTE within the past 3 to 12 months. Non-severe thrombophilia, recurrent VTE, and active cancer, which is treated within 6 months or palliative. Recent VTE, severe thrombophilia, including these particular conditions, come in the high risk. So high risk, more than 10%, moderate risk, 5 to 10%, low risk, less than 5%. For high and moderate, we have to prefer for bridging therapy. So what will be the bridging therapy in such a case? First, the most commonly used generally is warfarin. So discontinue warfarin 5 days prior to surgery. Point number one. Point two, assess the INR 1 to 2 days prior to surgery. If the INR is more than 1.5, consider a 1 to 2 milligram oral vitamin K to the patient. Point number three, for high thromboembolism risk, we have to bridge with a therapeutic subcutaneous dose of low molecular weight heparin or an IV unfractionated heparin. Low molecular weight heparin is much more preferred in this case. The last dose of low molecular weight heparin should be given 24 hours preemptively at half dose. If we are using unfractionated heparin, they should be discontinued 4 to 6 hours preemptively. For a moderate thromboembolism risk, the decision for bridging depends on the assessment of the individual patient and the surgery related factors. For a low thromboembolism risk patient, no bridging is required. In case there is a urgent or emergent surgery, 2.5 to 5 milligrams of oral or IV vitamin K can be given, and for immediate reversal, continue FFP or PCC in the patient. Now this is the stopping of the antiplatelet therapy, or basically the warfarin therapy, when you should resume. Resume the warfarin therapy approximately 12 to 24 hours after surgery when there is adequate hemostasis. In patients who were receiving bridging therapy with LMWH and undergoing a high risk surgery. So you can see whenever you are reading the statements or whenever I'm trying to explain, there are multiple components in a single patient. The patient has undergone bridging therapy, the patient was given LMWH, the patient had a risk. Now, if your patient is fulfilling all the three criteria, resume the therapeutic dose of LMWH 48 to 72 hours after surgery after adequate hemostasis has been achieved. 48 to 72 hours. Okay. In patients receiving bridging therapy with UFH, unfractionated heparin, and undergoing high bleeding risk, intravenous UFH should be resumed without a bolus dose at the same infusion rate as was used preoperatively 48 to 72 hours after surgery. So basically, in both the cases of LMWH and UFH, you are resuming at 48 to 72 hours. And this was the category of patient in which you had done the bridging therapy. Now, apart from warfarin, you have direct oral anticoagulants and the effects that these direct anticoagulants will have on your surgery. So the concept of stopping on particular anticoagulant therapy boils down to two concepts. If you have a low bleeding risk patient, you are aiming for a mild to moderate residual anticoagulation at the time of surgery between 12 to 25%. I'm taking a patient for a low bleeding risk surgery and I have stopped the anticoagulant therapy. My aim is to get a mild to moderate residual anticoagulation at the time of surgery, 12 to 25% of the effect. If it was a high bleeding risk, I want a no to minimal residual anticoagulation at the time of therapy, that is 3% to 6% of the effect. So in cases of direct oral anticoagulant therapy, we need to look at two very important factors. One, what is the patient's renal function? Because the creatinine clearance of this particular patient, the renal function of this particular patient is going to have an effect on the half-life of these drugs. So first we have dabigatran, which is usually given at a 150 mg BD dose, twice daily dose. Normal or mild impairment, the half-life is between 14 to 17 hours. In a low bleeding risk case, the last dose should be given 2 days preoperatively. Skip 2 doses in such a patient. In case of a high bleeding risk, the last dose should be 3 days preoperatively. you're skipping 4 doses. For a patient with yes, sir.
Sharp.
Yes, sir. Yes, sir.
2 days means we are skipping actually 4 doses. So 150 milligram twice, isn't it?
Sir, actually, they have taken the day of the OT in this column. So the day 0 and the day before, sir.
Okay.
They have actually, it was given in the description over there.
Okay. So that's why I wanted to be sure.
Yes.
Okay. Okay.
Yes,
So
sir.
day 0 is the day of surgery. Okay.
Day
Done.
0 is the day of
Okay.
surgery, and one day before, when you are giving a BD dose, you are actually
Okay.
not giving the BD dose.
Okay. Right.
And similarly, we have a moderate impairment. This increases to 3 days preoperatively and 4 to 5 days preoperatively. Now, this depends on the individual assessment of the patient. Similarly, we have for rivaroxaban. Again, the classifications come to normal or mild impairment, moderate impairment, and severe impairment. Majority classification is in normal to moderate, 2 days before in case of low risk, 3 days before in case of a high risk. In severe, increase it 1 day in both the categories, 3 days and 4 days. Similarly for apixaban, 2 days, 3 days, increase with 3 days and 4 days. Everything boils down to the half-life of the particular drug and the creatine clearance. Now you have stopped the drug. Now this was the stop column. Now when are you going to resume the direct anticoagulant therapy? Dabigatran, resume on POD1, 24 hours post-operatively, dose remains the same, 150 mg BD. High risk, high bleeding risk, POD 2 or 3, 48 to 72 hours. This is like the same management that we were going on for warfarin, 48 to 72 hours post-operatively, 150 mg twice daily. Rivaroxaban, POD1, you can resume. High risk, POD 2 or 3, wait. Apixaban, POD1, you can resume. POD2 or 3 in cases of high bleeding risk. So we have a basic idea that on POD1 and POD2 or 3, depending on the hemostasis and the patient behavior in both the cases.
I have a question.
Yes.
So, if we were using warfarin, we use something called bridging therapy. We continue with the low molecular weight heparin till the INR is back to normal.
Yes, sir.
What's the day of bridging therapy for the other oral antithrombins? Like dabigatran, apixaban, rivaroxaban. What is the bridging therapy duration?
Sir, in cases of actually for direct anticoagulant therapy, sir, we are actually stopping the drug just a day before. Like
Yeah, but then
considering
when you restart warfarin, there's a period of time that you have to give either unfractionated heparin or low molecular weight heparin till the INR comes back to normal, isn't it?
yes, sir. Yes.
So, what sort of bridging therapy do we need for restarting the dabigatran or rivaroxaban or apixaban?
Sir, actually, when I was reading this topic for the DOACs, I could not find out the
Yeah,
actual
because it's a difficult
bridging
thing,
therapy.
which is why
Yes.
I asked you. You don't actually, what they say is you don't need a bridging therapy
Yes, sir. We don't actually
because
need a bridging therapy.
you don't need a bridging therapy because their the mode of action starts very fast.
Yes.
Okay.
Half-life form.
Yes, half-life form. So it starts very fast. So you don't need a bridging therapy for, just remember that all of you. If you're using dabigatran or rivaroxaban or apixaban, you don't need a bridging therapy like you need for warfarin. Isn't that right, Dr. Upadhyay?
Absolutely, sir.
Okay,
Absolutely.
right.
There was a special consideration for this topic for a neuraxial blockade, that the spinal epidural or a combined spinal epidural procedure. In cases of anesthesia, there is an increased risk of complications associated with neuraxial procedures, and most importantly being the epidural hematoma. Epidural hematoma, while rare, it is a catastrophic complication caused by the spinal cord or the chordae equina compression and ischemia from the expanding hematoma, which can lead to severe neurological injury and paraplegia. This is mainly seen in, there is no, for a thrombocytopenic patient, there is no lower limit, nor no safe lower limit which has been identified for performing these neuraxial techniques. Platelet count between 70,000 to 1 lakh per microliter. The risk is between 0.2%. Platelet count between 50,000 to 69,000. Risk is 3%. And platelet count less than 49,000. The risk is 11%. So epidural techniques present a higher risk of significant bleeding than the spinal techniques, and this will add on it. This will be a add-on risk if your patient is already taking an anticoagulant or an antiplatelet therapy. So you need to be particularly aware if you want the patient to go through a spinal or a epidural procedure. So this was actually a big table in which they have particularly only discussed about the neuraxial procedures or the catheter remover. Similar condition on when to hold the medication before the puncture or catheter, when to restart the medication after the puncture or catheter placement, and similarly in all the tests. So it is better that we actually go through it on an individual basis, because a lot
So
of
the
things are
important thing is unfractionated heparin, it's 4 to 6 hours and 12 hours for low molecular weight heparin, which is why you'll notice that most of the low molecular weight heparin in most of the ICUs are given in the evening so that epidural cannulas can be taken out in the morning. Isn't that right, Dr. Upadhyay?
Yes, sir. Yes, sir. For unfractionated heparin, it is 4 to 6 hours.
Yes. But for LMWH, it is usually 12 hours.
It actually depends upon whether the LMWH is given as a prophylactic dose
Prophylaxis
or
or therapeutic, yes.
therapeutic. If it
Oh,
is therapeutic, then should be withheld for 24
24
hours
hours.
actually.
Yeah, yeah, yeah.
And you can resume the LMWH after 2 hours of removal of
I
epidural
think
catheter.
what Sharp has shown is with fondaparinux, the effect is longer.
Yes, Fondaparinux effect is longer, definitely.
yes.
স্যার when আর একটা জিনিস মিস করেছে মনে হয় বলতে, সেটা হচ্ছে যে এলএমডব্লিউএইচ কখন আমরা আনফ্র্যাকচারেড পেপার ইউজ করবো, ক্রাইটেরিয়াটা কি এটা মনে হয় বলেন।
So
আনফ্র্যাকশনেটেড হেপারিন এখন ইউজ করে না লোক, LMWH ইউজ করে বেসিক্যালি।
with one possible exception is if you need it suddenly reversed, because unfractionated heparin, you have something that can reverse it. Low molecular weight heparin, it's far difficult to reverse. Isn't that right, Dr. Upadhyay?
Yes, sir. Protamine is there for
So, I mean, at
reversal
least
of
for
heparin.
heparin, you have protamine, but then you have plenty of people who develop thrombocytopenia. The other
Yes.
issue, I think, is something that Sharp, will you please read up? I mean, I
Yes.
had one patient who was on hydroxyurea for thrombocytosis to bring
Okay.
the platelet level down. We
Okay.
came in with a platelet count of 9 lakhs. So I had to reduce it because he needed a transverse abdominal release for repair of a hernia. And then the moment I restarted him on LMWH, he bled. That was about 2 days after surgery. I thought my process was wrong. I might have left a bleeding point. Then Dr. Anupam Gulash, I asked him to repair the last gap. And exactly the same thing happened with Anupam. He bled 48 hours later. I think hydroxyurea affects platelet function. This man, I stopped his hydroxyurea 1 week prior to his surgery. So please read up. Hydroxyurea is used to bring the platelet level down, but I think it also affects platelet functioning.
Okay, sir.
Even many homeopathic and Ayurvedic medicines also have actions of anticoagulants.
Yes.
like
So
ginkgo and ginger, all those things. But there is no documentation. There are no studies when to stop or discontinue.
no, I mean, what happened was he was perfectly all right for 24 hours, and I thought he's going to develop a venous thrombosis, so I gave him a low molecular heparin. He dropped his hemoglobin from about 11 to 6. I had to give him blood
Mhm.
transfusion. I mean, he bled that much.
হাইড্রোক্সিউরিয়াসে কিছুটা মাইলোসাপ্রেসিভ প্রপার্টিও আছে স্যার।
হ্যাঁ করে তো কিন্তু প্লেটলেট ফাংশনিং এ গন্ডগোল করে কিনা I thought I was at fault till the same thing I asked the patient to go to Dr. Anupam Gulash to repair, and exactly the same thing happened to him 48 hours after surgery. So just read up about this. So, this is something that, thank you, that was an extensive uh, presentation, Shah. Well done. um, Dr. Upadhyay, do you want to add anything?
Yes, sir. Sharp has talked about emergency procedures when the
Mhm.
patient is still on DAPT, dual antiplatelet agents.
Yes, sir.
So
Yes, ma'am.
there are many school of thoughts. It should be stopped as early as possible when you feel that that surgery is important. And after 6 hours of last dose of clopidogrel, you can transfuse platelet-rich plasma, about 6 units.
I think
That
PCC,
PCC.
PRP.
yes, PCC can be given, isn't it?
স্যার ম্যাম রিকম্বিনেন্ট
PRP.
ফ্যাক্টর 7 এর কথা বলা আছে
না,
7A?
basically, না, না, না. What the recommendation says, PRP, platelet-rich plasma should be transfused,
Okay.
and it can reverse 40% of antiplatelet effect of clopidogrel, because all of us know that clopidogrel has a irreversible platelet function effect.
Hmm.
So
Yes.
40% can be reversed, and the surgery should be done within 6 hours of transfusion of last platelet.
Okay, ma'am.
And another thing which is have been proven in studies, you can use desmopressin,
Desmos.
EACA. Tranexamic acid basically reverses the effect of tide of fever.